All right, so I think we're live. So welcome back to the fall episode of the Analytics and Palliative Care Journal Club. It's great to be able to do this again with my colleagues, Drs. Amy Kelly, Martha Twaddle, Dana Lustbader, Janet Bull, Caitlin Brennan, who regrettably cannot join us today. And of course, we have a very special guest that I look forward to introducing. My name is Len DeVolio, and our topic today is near and dear to all of our hearts, I'm sure, understanding preventable spend among high utilizers. Hopefully everyone was able to download the study, concentration of potentially preventable spending among high-cost Medicare subpopulations. Whether you were able to or not, we're still going to start with our traditional sort of 30,000-foot view of the study. Reminder, we are recording. If that is offensive in any way, hop off now so you don't get caught for whatever misdeeds you've been involved with. We will be posting this to the Cyft website. We post both the podcast and the video versions of this so folks can partake in whatever format works best. Please send questions via the Q&A button. We will be curating them, and we will introduce as many as we possibly can during the discussion portion of our session. Now, I'm really excited to be able to introduce my former colleague at the Department of Veterans Affairs in Boston, Massachusetts, and currently cardiologist at WashU and Barnes Jewish Hospital, the co-director for the Center of Health Economics and Policy at the Institute for Public Health at Washington University, associate editor for health policy at the Journal of the American Medical Association. Her research is a fantastic blend of policy and practice. It sort of steps back and asks the question, have these policies achieved what we hope they would? And it provides fantastic insights for both policymakers and clinical leaders looking to design programs that will help them succeed in value-based programs. Dr. Karen Joynt Maddox, thank you so much for joining our journal club.
Thank you for having me. Looking forward.
All right, so the reason we chose this study, there's two that I think I really hope people sort of walk away with. The first is that this study helps us understand that those that cost the most are not necessarily those most likely to benefit from intervention. And I think this is critically important because although this may seem obvious when I say it, the vast majority of risk stratification algorithms and care management programs are designed to identify those that cost the most. And if we can use data to discover the differences between those that simply cost a lot and those we can help, then we can design more efficient programs that are more likely to help the patients most in need. The second reason I love this study is that it shows what other industries have been proving for decades now, which is we can move data to move beyond one-size-fits-all views of the world to start understanding at a more granular level the individuals we can help and matching them to the interventions they're most likely to benefit from. And I think Karen and her colleagues do a wonderful job of showing us exactly how this could work and teaching us a lot in the process. So let's get into the study. It is grounded right from the start in the intent to support folks involved in value-based care and value-based contracts. And the authors list right in the first paragraph examples of the types of contracts and policies where now it is becoming critical for clinical leaders to find areas where they can save cost by reducing unnecessary utilization and improve quality. If you can't save cost and improve quality, you can't succeed in value-based care, and that is the stated incentive for this work. The three questions the authors set out to address in their work is, number one, what proportion of spend may be preventable? And they use this idea of breaking the population into 6 subpopulations, which is applied throughout the study. So how much of the spend is preventable, and then looking at it even further by these 6 distinct groups. How do the amounts and types of spending diverge, change? what types of hospitalizations drive preventable spend among the subgroups. Let's hop into methods. And again, we're running through this quickly. And if you have questions related to methods, just throw them in the Q&A and we'll come back around to them. But the data set used here is 2011, 2012 Medicare data. That's Medicare fee-for-service data, mostly because they excluded MA. Although I think, Karen, duals are involved in this as well, correct?
Yep, duals are there. Just we don't have encounter data for Medicare Advantage, but any fee-for-service primary payer Medicare.
Great. So what they did is they took 20% of each file. They excluded Medicare Advantage folks, and then they exclude anyone that they don't have 12 months of continuous enrollment for. And I think we're going to come back around at that because there are real interesting repercussions to that. So I threw an asterisk on it, so you know it's special. That leaves them with more than 6 million beneficiaries that they studied. And they used existing, validated, currently in practice CMS methods for calculating patient cost. And that includes using regional rates, because we know that healthcare cost more or less depending on what part of the country you're in. Of course, of the 6 million, they focus even more narrowly on the top 10%, sometimes referred to as super utilizers, high utilizers, and that leaves them with 600,000 folks that fall within this category of top 10% of spenders. So how do they define these 6 subpopulations? Well, they use a previously described claims-based algorithm called Bridges to Health. And all of I think what they do a wonderful job of is all of their methods are described in greater detail in the appendix of the study. And I think most of the algorithms are reproducible. So I'd highly encourage anyone who wants to figure out how to break their own data into these subcategories to go look at the appendix of the article. This approach was developed with a multidisciplinary team, and it was developed as part of a workshop hosted by the National Academies of Medicine. And what happened here is basically, I would say that, and Karen can correct me, it's a rules-based approach, entirely based on claims. And I would say it's sort of expert-driven. They had a roundtable where they basically hashed out what sets of subpopulations, and then further, what would we look for in the claims to divide people into these subpopulations. And what they arrived at were these 6 groups: the non-elderly disabled, frail elderly, major complex chronic, minor complex chronic, simple chronic, and relatively healthy. I pulled one example, and the group that I pulled it for is probably the most relevant for this group and the study. So to find frail elderly, they took folks that were 65 or older with at least 2 of the following conditions listed there, taken from the claims. I think it's important to note that no one person can be in more than one group in the way that they designed this. So it's basically a waterfall where you start with folks under 65 and they go in one bucket. And then you move down to frail elderly, and there's the definition right there. And if you don't meet that criteria, you slide down the ladder to chronic conditions, major, minor, simple, then relatively healthy, so that every patient in the population of 6 million, and then the top 10% of 600,000 fits into one of these buckets. Okay, so how do you define preventable spend versus absolutely necessary medical spend? Again, they use an existing algorithm, and they broke it into 2 types. Number 1, hospitalization. Number 2, ED visits. There are 2 different published, validated algorithms for these 2 different events. For hospitalization, they use the AHRQ Prevention Quality Indicator software. And what this does is it looks for conditions that we believe can be addressed outside of the hospital, and these are ambulatory care sensitive conditions, or ACSCs. This algorithm is not just validated, it's actually in use by CMS as part of some of the quality measures that they employ to pay folks that are involved in some value-based contracts. So validated, widely used, highly relevant for value-based care. And then ED visits. They use the Billings et al. Algorithm, which has been published, I think more than once. It's been validated. We use this algorithm. It's sometimes referred to as the NYU algorithm. It basically, like the hospitalization algorithm, looks for a set of conditions that are believed to be addressable outside of the emergency department. And so these are if you fall under this category of event with these types of ACSCs, that's believed to be a preventable spend. And so they're calculating all costs, but then subcategorizing into preventable cost. I think I should note, no claims-based algorithm is perfect, but I do appreciate that they chose wherever possible, widely validated algorithms that are relevant to value-based contracts and used by CMS today. Okay, so the analysis that they conducted categorized the spending into the following categories. What I really like about this study, and it may have been novel at the time, is they don't just stop at incurred cost from the event itself. They then look 30 days further following the event, and they roll up all of the 30-day post-admit expenses to get a handle on the total cost. They then compare the 6 subpopulations by amounts of preventable spend and types of spend, and they calculate the variation by subpopulation in terms of not just whether or not it was preventable, but the types of ambulatory care sensitive conditions that were incurred that helped incur the cost. Results. A quick sip so you all can do a mental drum roll. Okay, so the first answer to the question posed, how do the subpopulations break down in? So you take the whole population of 6 million, everyone gets assigned to one of these subpopulations. How does that break down in the total population of 6 million? And you can see you have the minor chronic complex is about 28%, major complex chronic 18%, simple chronic 18%, non-elderly disabled 18%, relatively healthy only 10%. And then the frail elderly is the smallest of the groups in my little Zoom windows in the way, but if I remember correctly, it's 8.6%. Okay, so then when you move from the 6 million to the 600,000, and these are the top 10% most costly, then what does the distribution look like by subgroup? And if you move to the bottom of I kept them in the same order that they were reported, but if you move to the bottom of this table, you can see that the frail elderly makes up 46.2% of everyone that is among the most expensive. So from 8% up to 4% in the total pop, to accounting for nearly half of the most expensive patients. And then you can see you work your way up. You have the major complex chronic and the non-elderly disabled, et cetera. So how much of the total spend was preventable? Well, in the big sample of 6 million, 4.8% of every dollar spent is preventable. So of $100 spent on delivering healthcare, 5 of those dollars are preventable. But when you move to the top 10%, a full 74% of the total preventable spend occurs within the top 10%, right? So of the total spend, 5% is preventable, but 74% of that preventable spend happens in the top 10% of most expensive patients. I'll do my best to keep these numbers straight and try to explain them clearly, but there are lots of them, so we'll take it slow. All right, for the next few slides, I have borrowed the figures used by the authors because I think they do a really nice job of presenting really powerful information very clearly. So what is the proportion of preventable spend by subgroup? Well, in the high cost, you can see that very tall bar, 43.4% of the spend amongst the frail elderly is preventable. Moving down the ladder to 4.8, 11.2, et cetera. So of all of the dollars spent within the high cost group, 44 out of $100 is preventable within this very specific group. That's 44% of their total spend is avoidable spend, according to the study. What does that translate to in terms of actual dollars per patient? Well, within the non-elderly disabled, that's $3,400 per year per patient is, or per 12-month period per patient is preventable. It's $6,593 per patient within the frail elderly population is believed to be preventable. And you move down the line, major, complex, chronic, and you can see some pretty significant variation here in terms of both percentage and total dollars. Okay, so if you wanted to look at which subgroup, what percentage of the population is made up by the subgroup, and then what percentage of the total preventable spend do they make up? Again, frail elderly just jumps off the page. They're only 8.6% of the total population, the 6 million, and yet they make up 51% of all preventable spend. There's no other number that comes close. Moving on, they then break down the average per patient spend by subpopulation. And here in this graphic, for the first time, we're looking at those ACSCs. So what type of hospitalization or ED visit are we dealing with? And this is useful because up until now, we've been looking at which subpopulations have preventable spend, but now we begin to introduce, okay, so what are the conditions associated with that preventable spend? So we sort of turn the study on another axis, and what we find is, again, frail elderly sort of jumps off the chart in terms of the average per patient dollars spent per 12-month period. And you can see heart failure is the most expensive, and the frail elderly there make up a pretty significant per dollar spent per patient, bacterial pneumonia, urinary tract infection, et cetera. I think what's most important about this is you do see variation in which subpopulation is accounting for which ACSC and dollars spent. So it starts to steer us towards specific interventions by subgroup based on where the most preventable dollars live. Moving to discussion, I think it becomes very obvious, and the author stated, I've taken quotes from them, large variation exists across high cost subgroups. The good news is I'm almost done talking and I get to hand this over to the panel. The high cost frail elderly group accounted for nearly half of the potentially preventable spend. And it suggests for clinical leaders and policymakers, focusing on this subgroup may be efficacious. Speaking to that very last slide, with nearly 80% of spending for heart failure and bacterial and 70% of bacterial pneumonia coming from just really two of the subpopulations, I think you start to paint a picture of moving away from care management for highest risk to something that looks like a pneumonia prevention program for two very narrow subpopulations, being a way to focus your limited dollars toward patients most likely to benefit. And I'm not saying that's the answer, but I am saying the data starts to indicate more granular approaches. The opportunity is to use the data to match individuals to most appropriate interventions. Okay, so with that, hopefully you all have questions that you're putting in the Q&A. I have a brilliant panel of clinicians and researchers that are focused on just this subpopulation. So let's open it up and start to talk about what we take from this really interesting study. And I would like to begin by asking our esteemed guest, did you expect so much of the story to be about frail elderly when you set out to study where preventable spend lives amongst Medicare population?
I would like to say that we knew what we were getting into, but actually no. We sort of thought that the complex chronic group would have pretty similar spend. And then we realized that actually your point about them being mutually exclusive is an important one. Because if you identify people who are starting to decline in terms of functional status, and if they have those key elements that indicate frailty, then no matter if they have heart failure or COPD, they have plenty of underlying illnesses, but those functional status decrements start to indicate a group that is just much, much sicker than everybody else. So essentially, we're almost segmenting our heart failure patients and our COPD patients and everybody else into this group that is starting to fail in terms of their functional status. And I think in retrospect, we should have expected that, because we're basically picking out these like fantastic markers of really someone struggling. But we thought going in that a lot of the spend would actually be in the vast number of people that just have chronic disease.
And I would say to my panelists, don't be shy. I've listed a few seed questions here, but as is always the case, it sort of goes left and right. So I'll ask, before I sort of put up the next canned question, if Janet or Amy, Martha, Dana, you have questions about this really jump off the page frail elderly conclusion.
I just would like to know what other surprises came from looking at this data that you didn't expect.
I was surprised at how easy it was, or how powerful maybe these indicators were. You sort of realize that something like a pressure ulcer or a claim for a wheelchair, there are pretty easy things to find in claims. We actually thought it would be harder to identify people with frailty, because you sort of hear that frailty is a clinical diagnosis and you cannot define it in claims. And that may be true technically. What we were able to find pretty easily, though, is a signal that someone is likely to be frail. So I will absolutely admit that the frailty index is an imperfect surrogate for frailty, but it's a really good marker. And it takes a pretty small number of things actually to start to find this. So we were actually surprised at how easily we could implement this. Now, this has been since updated. So we took this list of things from an initial paper by Sebastian Schneeweiss's group, Kim et al. Is the first author, where they identified these as sort of theoretical, and then they subsequently went back and built out a very complex algorithm that pulls not only these but a whole bunch of other diagnoses to build a points-based frailty index that we now use instead of this one. But I will say we were pretty shocked that just what looks like a pretty simple list of things, you just have any two of these and it could put you into that really, really high risk category.
I think we definitely see that in clinical practice. The frail individuals that we take care of don't respond as well to treatments. They don't do as well when they get hospitalized and have insults. So it's not surprising to see that.
And I think right there, you just did a nice job of answering a question from our friend Zev Nurath related to whether there's a more recent study that attempts to categorize frail elderly. I also flashed the screen where we used your definition of frail elderly, because that was asked for as well. Are there other, I have a question related to frail elderly, which was basically, I'd love for our clinicians to talk a little bit about the concept of frail elderly in practice. Dana, Martha, Janet, any thoughts on, do we really think about frail elderly as its own thing in practice, and how does that work or doesn't work today?
One of the things as we look at frail elderly, and I think it ties into why so often our single organ case management programs fail in the Medicare population, is that a lot of people have multiple chronic conditions or have frailty, and slapping on a heart failure program or a post-hospital discharge 30-day program to them fails because they're just complicated or frail or debilitated, or they can't get to the clinic for their post-hospital discharge visit, or just working on heart failure misses everything else. And I think what we see is sort of the dwindles. We see this population with multiple markers of frailty and multiple chronic conditions and just dwindling. And there isn't anything really good that serves them except a really responsive healthcare ecosystem. And that's hard to build. I'm really curious from Karen's perspective, how she looks at, what is needed to serve this sort of complex, frail population.
I think what people need is a helping hand. I mean, that sounds sort of corny, but by the time people have gotten to the point where they're developing these signposts of frailty, it becomes an almost unmanageable set of problems generally, right? So I've experienced this with my patients, with my parents. once you get to a certain point, what the health system is asking you to do in terms of coordinating what your cardiologist says to do, what your pulmonologist says to do, and what your primary care doctor says to do, and what your discharge paperwork from the hospital was, it is an impossible task. I had a personal voyage of discovery in trying to help my mother with this and opening up a drawer where the medications were and just went, oh my gosh. I don't think we have we in trying to be patient-centered and let patients sort of make decisions and drive the ship, we have, I think, forgotten just how difficult of a task that is. And so I think what people really need is the sort of wraparound support to be able to help coordinate all this stuff once you get to a certain level. And that requires finding the people that need that sort of support. It's expensive. You don't sort of want to do that for everybody, but you find the people who really need it. And I think that's where you can really add value. And I know, I'm sure we'll get to this additionally, but that also sometimes means someone who can step in and say, when we're not going to do additional things, when we can align goals and, you know, what we're sort of doing with people, it becomes, like you said, not something you can fix in a one-time clinic visit. It needs to be a longitudinal sort of caregiving, guiding kind of relationship once you get to the point of developing frailty.
And I'm so interested to hear that response. And I'm wondering, kind of to take that a step further, much of what you're talking about is an assessment of care needs or limitations in activities of daily living and instrumental activities of daily living. Bringing together that clinical perspective with your data perspective, I've always found it challenging that those are not the actionable items that we're actually measuring in our existing data. And so I wonder about your experience using these proxies for frailty and then the clinical setting where you need to actually know how people are managing their lives and how we might think as a community about bringing those measures together in a way that is a little more pragmatic.
That's a terrific question, and I'll answer it and then give you the additional thing that you brought up that I think is super important. So the answer to that, I think, is that claims-based markers are terrific for sort of population-based analyses. I am certain that as a group, the frail people in this study are different than the non-frail people. They're not very good for the individual, right? It depends on who codes what and who you see when and all those sorts of things. If you actually want to do something for somebody, you need to get to them. So I think these things are very useful in terms of flagging to whom should we then deliver some sort of more personalized assessment. And this would be a good way actually to screen out people who would not necessarily need a deeper dive into those sorts of things, because even though they do have some chronic diseases, they're actually doing okay. The other parallel to that, I don't know if anyone wants to go down this rabbit hole exactly, but social risk is very similar. You can't use claims, you can't use big data to identify with precision what one person needs in terms of their social risk. But you can absolutely use these data sets to trigger who you need to go in and have a deep conversation with about their needs. And that probably shouldn't be the doctor, probably shouldn't be the surgeon who's about to do the surgery. It should be social workers and nurses and nutritionists and all those support services. And again, to me, it's a screen in, screen out function with the big data that you can very quickly get much more efficient in how you're going to start delivering those services by relying on the data for the sort of first step.
There's a question in the Q&A about, so given what you know, how would you go about segmenting a Medicare population? And I guess I don't want to take a shot at answering it so much as putting out some food for thought. We know from the geriatric literature that looking for indications of frailty are much stronger predictors of upcoming utilization than specific conditions. So would you say that your study paints the picture of identification via frailty as opposed to our traditional ways of doing it, which I think Dana had described it as organ-based or single organ-based or disease-specific? Could you argue that we should be using indicators of frailty as a way to prioritize folks as opposed to alternative methods?
Yeah, I think just to suggest what types of interventions people might need, absolutely. It might be that you have a low cost, low touch intervention for someone with diabetes who is not frail. But your sort of high touch, high cost sort of interventions need to be targeted to people where you're going to be in a high cost, high spend sort of scenario where you can really make a difference. And that is much more about your functional status than it is about which diseases you have. So I think it depends what you want to deliver, but it certainly argues that for the, sort of in-depth kind of care management, that you're better off identifying by frailty than by any specific disease, with the possible exception of heart failure.
Any other thoughts from our panelists on that question? Just to rephrase it, given everything you know, how would you stratify groups? By what dimensions are most important?
Well, Karen, this is Martha. I think I found this really exciting that you were able to identify frailty using claims, because that to me, as listening to this and contemplating, that should be how we identify where we go first, is who's at most risk, not who has what illness. And this is quite a pivot in terms of how all our systems are set up, how we would prioritize who needs a goals of care conversation in our hospital rounds. It shouldn't be just the fact that they have heart failure or cancer. It should be the frailty first and then the diagnoses afterwards that would help us reprioritize. So this is really fascinating to think about implementing this and not at a $6 million, or 6 million population, but at smaller populations. And how can we do that effectively?
Yeah, I think that's a great point. And in our health system, we've been using a palliative care trigger tool sort of built out of the EMR to do that sort of thing. And it is much more effective than the disease-based trigger, at least in the initial testing. I will say that I think this is indicative that we need a bit of a frame shift, not just in sort of figuring out where the care management needs to go, but also on the policy side of figuring out how we're going to risk adjust to pay and how we're going to design programs to focus on the patients who can benefit the most from, these sort of novel kinds of interventions. Someone asked in the chat about the HCC model. The HCC diagnosis score specifically doesn't include these things for the most part. There are some that are in there, and if you look at the risk adjustment models for things like heart failure and heart attack, it's what a bunch of cardiologists, sorry, these are my people, but what a bunch of cardiologists told CMS they should put in the risk adjustment model. So it's, do you have diabetes? Do you have peripheral artery disease? Do you have, a set of very concrete medical diagnoses, not what is your functional status? What is your social support? Have you used a wheelchair? And so actually many of the risk models that perform really poorly, particularly for things like readmissions and long-term spend, in part do so because they're anchored in this very sort of disease-based biomedical model, as opposed to this much more functional and social-based, almost like holistic patient-centered kind of model.
What struck me was that when you look at the preventable spend of this population, which is a little over $6,000 a year, if you have a good palliative care team and you have a value-based contract of $500 a month, I think you can see where you can save costs potentially and get much better outcomes. So the math actually works in this population if you can surround a patient with an interdisciplinary team and really send those nurses and social workers in to help you with that care management aspect.
So I'll just follow up a little bit to Yvonne's question related to the HCC diagnosis, because Karen, you're absolutely right. They're based on disease and complexity of disease as opposed to frailty or functional status. But I think when you look at the way CMS has attempted to define the high needs population as part of direct contracting high needs, if the average Medicare beneficiary has an HCC score of 1, it's not at all uncommon to see the high needs population have HCC codes that approach 3. And what it basically means is statistically, they're more likely to spend 3 times as much as your average beneficiary. So while they don't do a good job of using frailty to assign the score, there is an obvious, and the study shows it, an obvious correlation between frail elderly patients and what they cost. But they're not tied together. I guess they're they're correlated,
Yeah.
not by design.
I just want to pull a couple of questions out from the chat. George asks, if there are any subpopulations within the frail elderly subpopulation that we could even focus on more, given that the frail elderly population represents 8.6% of the total population, but almost half of the total cost.
That's a great question. We did not further segment them. And my sort of offhanded heart failure comment probably stands there, though, that we do know that that is such a high risk condition. And actually one that we've done so poorly in terms of palliative care and sort of patient-centered decision-making in, that you could imagine that within that group, there may be a couple key clinical things where you might want to deliver a slightly different set of interventions. But I will admit to not having segmented that group farther. It's a great follow-up question, though.
And Karen, another question from Mark, in terms of polypharmacy, how does that impact risk stratification, in your opinion, to subpopulations? Is it useful, or just too ubiquitous to be useful?
Yeah, that's a great question. So we didn't have pharmacy data for this study. It was, we did this a while ago, and the data at the time for Part D, anyways, we didn't have it, we didn't use it. And you could probably do that better now, because Part D has gotten so much more both common and sort of workable in terms of the data and how it comes in and all those sorts of things. For many of these value-based things, right, the pharmacy costs are actually carved out. Mm-hmm. And so in this case, you might have used them as to identify people who were likely to be high cost, but ironically, that would not necessarily have included the drugs. It's an area of active debate, because there are some, as I'm sure you all know, things like drugs for Alzheimer's, for certain cardiovascular disease, there are extraordinarily high cost drugs coming along that we're not quite sure how to pay for, how to deal with, how to think about in value-based care. So that's a terrific question that has many, many layers of complexity that we've not yet, I think, collectively figured out how to deal with.
And just one last question, just from my own experience. There's so much pressure as these programs are being built out, either by vendors or local programs or health systems. And there's this pressure to demonstrate return on investment, in-year return or 2-to-1 return on investment, or some kind of value. And often the runway's short, a year or even 2 years. As you look at the frail elderly population, which is messy and complicated and the biggest driver here, how do we think about extending the runway for programs to demonstrate their value and is 2-to-1 ROI a realistic return?
Yeah, that's a great question. There's two sides to that we could do better in two different ways. First, I do think that there is probably opportunity for acute return on investment in the frail group, in part because the costs that they're going to incur tend to be so high. It's not just the hospitalization, it's an extended hospitalization and post-acute care and. So that actually may be a group where targeted appropriately, there is an ROI because of the sort of downstream effects of any event that you can prevent. But to get a little more meta and to perhaps knock my own study a little bit, the definition of preventability is a little weird, right? You don't count things like heart attacks and strokes. Plenty of things are preventable that we don't count as preventable, because we were also locked into this sort of short-term mindset. So if you're thinking from a much bigger, space about preventability, sure, we need to manage blood pressure and diabetes and all that sort of stuff. And the long-term preventable costs are very different. This was very explicitly focused on these sort of near-term costs, which are going to be higher in people who have frailty because they are experiencing these active events at such a very high rate. From a population standpoint, it's probably a different calculus. From an intervention standpoint, most of the ROI is going to be on people who are going to have very high frequencies of events in the relatively near term.
You raised a great point. When you look at ROI, it's always a bean counter looking at the financial savings. And you're right, the other benefits, improved quality of life, a reduction of MI, or improvement in other outcomes, isn't valued.
Especially if they're past 30, 60, 90, or 365 days.
Right.
So Zeb in the comments had asked, is it more on the subject of intervening on this population? Is it more effective to have a separate comprehensive clinic model? What approaches have you all taken or seen effective? For my money, so the frail elderly population by definition is not making it in and out of most clinical models because they're unable to travel oftentimes. Oftentimes they live inside of facilities already. So I actually do believe that you do need a separate model to care for this population, separate than your traditional clinic-based or hospital-based comprehensive care program. And I think if you're looking for a model for my money, it's PACE. I don't know if others have opinions on how best to intervene on the frail elderly populations.
And Len,
You know,
just
Len-
to
oh, go ahead.
dovetail into your question, Len, Lori Bishop also poses this too, as we think about the percentage of frail elderly that might have died and in what time frame, in addition to PACE, is hospice care. And, you know, would these frail elderly have been better served if they had been enrolled in hospice in a more timely way? So I'm curious, Karen, from your perspective, what percent of the frail elderly died within 6 months, or do you have a sense of who could have been better served?
Yeah, so in this study, we excluded people who died because the end of life costs, sort of amortizing them over time, was a little complicated. And we were trying to get at sort of the chronic, if you're going to target someone, sort of issue. But we looked at it both ways. As you can imagine, we're very interested in end of life care. And it is even more striking how much more costly frail individuals are if you also take into account end of life care. Where we struggled was that there was disagreement, and we're in a different place 10 years later about whether or not you should count that kind of stuff as preventable, to give the impression that you're like withholding care. The balance of how you talk about end of life and what meets people's preferences versus what they want, that can be tough. And so we felt uncomfortable throwing it into the preventable cost bucket without sort of further discussion. But it is preventable costs, and it can be very patient-centered, very goal-aligned preventable costs. And so it really should be part of the conversation. And I'll sort of agree on the prior comment that this group probably needs a different type of intervention than a less frail group who needs help with like managing the diabetes or managing the blood pressure. This is much more about these big picture kind of questions, and probably does require maybe not a separate entire clinical team, but it requires a team that's really in tune with this kind of stuff, that can do home visits, that has connections of palliative care and hospice, just a different mindset, I think, for this type of care.
I think this group particularly lends itself to telehealth support because they still need robust care and they need collaboration of multiple different service lines. And you don't want to exclude them from accessing ambulatory, but the effort to access ambulatory needs to be met with a collaboration of their doctors all seeing them at once. And so perhaps that can be facilitated through having a clinician in the home, but having a telehealth of the consultants who are collaborating. And obviously I'm kind of pie in the sky, but if that's what they really would benefit from, is more of a team, even of their different physicians and APPs that are coming together to serve them.
Yeah, I love that idea, being able to get everyone, even if, maybe a clinician is in the home with a patient and the other clinicians are there on telehealth. I mean, there's many ways that you could imagine creative ways to sort of get healthcare to where they are. This is unpublished, but we've been looking at data from the last year during COVID and looking at people that are in care facilities and looking at hospitalization rates. And we know that hospitalization rates absent COVID dropped, right? People just didn't go to the hospital for whatever. And part of what we think we're seeing in the data is that people figured out how to manage more stuff at home. Some of that may have been telehealth because the rules changed quite a bit during COVID. Some of it may have been more just figuring like, all right, normally we'd say, well, we better err on the side of caution and send this person to the hospital, which seems like a good idea and can have such bad downstream effects. Someone gets confused and their meds get changed, and right, you know how the snowball goes for people who are already sort of teetering and frail. It just suggests that like we can learn from this, keep people where they are, bring the care to them, keep people out of the big scary hospital a little more than we've been doing. And maybe we can study a little bit of the disruption over the past year using some of this data and see where there might be kind of a there for the kind of disruption you suggest.
So Karen, I don't want to move past a point that you just made earlier related to palliative and hospice, and Dana, you made this point as well. So we work with people that proudly call themselves palliative care providers, and we work with people that are geriatricians to the frail elderly population. And I find in many cases that's more of a professional distinction than a difference in the patients that they're caring for. And what really jumped out to me when I read this study, having done prior journal clubs about the potential cost savings of palliative care, is that the greatest opportunity for cost savings in the last year of life is in the last 3 months of life. And Dana's study that we looked at made that point very clearly. And just to reiterate, your study left out, for very good methodological reasons, that period of time. And the frail elderly, where most of the savings existed, is more often than not, in the vast majority of cases, that same population. So the big takeaway for me in reading it was, so the vast majority of preventable spend takes place amongst the frail elderly, and we're not even accounting for preventable spending in the end of life. So this is a ringing endorsement for a comprehensive approach to geriatric care that includes, as a member of the team, your palliative care clinician, and when appropriate, your hospice team. That's where the quality goes up and the potential cost savings for reducing unnecessary and unwanted care goes up.
Yeah.
Do you see it differently? I don't.
No, I totally agree. I mean, part of the trick with end of life care in general, end of life care research in general, is that retrospectively, it always appears quite evident when the end of life was going to be, right? In the moment, it doesn't. We spend all of our time in the hospital trying to fight off the end of life. And so it is, I think it is a little bit, so in a broader population, it's a little tough to go back and say, well, we didn't have to do all that stuff at the end of life. Well, we did it last, 3 months ago, and it wasn't the end of their life, right? So you sort of can't forego that, with the potential exception of people who are frail and older, where many people may not want us to be doing all that stuff at the end of life. So this is actually a group in which that end of life spending is not only enormous, but it is actually much more preventable by the appropriate type of care that you're talking about than it is when you look more broadly, where I think we overestimate how much of end of life care is preventable in the general population. But in this group, I think you're absolutely right that we have very much underestimated how much of their spending is preventable because of the way that end of life and hospice care should look so different in someone who has been chronically developing frailty.
There are a few questions in the chat about, can you use, it really is about patient, and you touched about identifying the right patient sooner. And one question is related to, can you really use claims, or does this progress too quickly? And claims, of course, is delayed. And there's another request for triggers to find these types of patients. I will just say, having a few years of experience running an analytics company focused on these populations, our dream would be for the electronic medical record to include natively indicators of frailty that one could use to find people sooner. And that electronic health record could be available to everyone. That's not the case. I will say that in practice, yes, you can use claims data to identify indicators of frailty. Karen and team have done that. You can use claims data to successfully predict patients that are nearing end of life. You can combine models that look for patients that are nearing preventable events and are nearing end of life. And this is what we do most frequently when we're dealing with high needs, frail elderly geriatric populations. And I would suggest a really basic starting point would be to simply take either one of the algorithms that we've studied in the past as part of this journal club or Karen's as a basic starting point. Look for these basic indicators of frailty. And I would think that would start you down the road. I would also suggest, as we've been discussing here, finding the right patients is not helpful unless you have interventions that are designed for frail elderly / end of life. It could just be me, but I've yet to see a generic care management model make a big difference for this largely homebound patient population. It needs to be interdisciplinary. It needs to focus on frailty, polypharma, falls prevention, home-based via telemedicine or in person. So one without the other is sort of a useless exercise. And I always advise folks to answer the question, what will we do when we find them, before worrying too much about using the math.
It's actually a great question though, and we didn't do this, but one with more data expertise could, is that I would suspect that some of these elements that are associated with frailty actually show up in the medical record a lot earlier than we think. You know, I know with my own parents going through some medical issues, we now look back and see, oh, the taxes are wrong last year. Oh, there's like so much that predated. And I would bet that if you did sort of trajectory kinds of studies, that you could find some key things that would actually pop up far enough in advance that you could maybe even push off the development of clinical frailty. That is not what we looked at here. So I don't want to claim that this would do it, but that would be sort of the next step back, would be to say, can we identify such early markers of frailty that we can actually go in and keep this person from having that hospitalization or whatever sort of starts the sort of downward spiral. That's aspirational, but I wouldn't be surprised after seeing the power of some of these variables, if even a couple things start to pop up, you could maybe see a trajectory.
Karen, I'm curious if you had any kind of proxy for quality of life, because we've done some work to show that as people's functional status declines, their PPS score, their palliative performance scales goes down, their quality of life goes down, is how they rate it. And usually from clinical experience, those are the people who don't want to go back to the hospital, right? They're tired of all these interventions, they're tired of all this. And then we align kind of their goals with their medical treatment. And I wonder sometimes if we had a way that we could measure their quality of life based on, their frailty, how that would impact care and what we could do to help support them.
Yeah, that's a really interesting point. So we in the claims we don't have that, but I have wondered more and more recently why it is that we pay for blood tests, X-rays, stress tests, any number of things that radiate people or do other things, take their blood. And we don't actually pay for like measuring quality of life, or there's plenty of things that are actually quite valid measures of people that we should be tracking longitudinally, and we should be reimbursed for tracking longitudinally if we want people to do that. If you paid for that stuff, people would do it pretty quickly, and we just don't. We prioritize these, much more, I don't know, less squishy kinds of things, but like really what you want is you need the squishy stuff, right? So.
Yeah, it's fascinating.
And I think one of the things, Karen, it sort of demonstrates, people do what they get paid to do. And, if you get paid to do the stress echo and admit people to the hospital, that's sort of what happens. One of the questions in the chat I just want to run by you is someone asked that since the data was looking at 2012, Alan Rosen wondered, how things might be different now. And you talked a bit about COVID and hospital admissions going down, although they seem to have rebounded, the non-COVID admits. But what might be different now, and what might be happening out there in the wild with more telehealth, for example, and more folks doing home-based care that might make your results different today or reinforce what you found?
I'm not sure about the intervention question. I can say that we've continued to use not this frailty index, but the subsequently validated one that's more complicated to code. But once you've got it coded, it's quite easy to use, and it's been updated to ICD-10. It is immensely predictive. And I did some work when I was at ASPE, the Assistant Secretary for Planning and Evaluation at HHS, that came out in a couple of reports to Congress, looking at how adding those frailty elements to current risk adjustment models would change them. And they do, even in current, up through, what have we looked at? I guess we looked at BPCIA. So up through 2019 data, we haven't done anything with 2020 other than COVID stuff, because goodness knows, ascertainment's down, coding, I mean, who knows? But I will say for value-based payment programs through 2019, I can say with quite a bit of confidence that the frailty indicators predict utilization and spend well beyond the current models that are being used. So it remains quite powerful. If anything, we're seeing a higher prevalence over time, right? I mean, the population is aging. We're keeping people alive through all sorts of diseases that would have previously not been survivable. I think this will become an even more and more important sort of area going forward.
There are a couple of questions, and we just have a few minutes left, that I would group in the category of, so what interventions have we seen that worked? There's a question about mobile urgent care to avoid ED visits. There's a question about what other, so we discussed bacterial pneumonia, what other bundles might help. I personally am aware of falls prevention. I mean, the usual is falls prevention, early dementia detection, and dementia care. Polypharma is big amongst this population. Are there other best practices, bundles, or programs folks can think of that we should toss out there?
I think in general, I can say that where the data, I'm most familiar with the heart failure version of all this stuff for the whole cardiology thing, but the data for that group of patients is pretty strongly in favor of high touch programs with a sort of care team leader, usually a nurse practitioner, and that a lot of the other programs, when you try to then replicate them broadly, don't work very well because it requires sort of one very dedicated person basically holding your hand and helping you manage things. So at least from the geriatric heart failure world, those tend to be the most promising in terms of reducing utilization. And I think in part because they do get at end of life and sort of those big questions around what we do. I think this group has been grossly understudied. We've not put enough energy into thinking about these functional group defined as opposed to disease defined types of interventions.
Well, seeing as we're coming to the top of the hour, I think we've only scratched the surface on this incredibly important but understudied population. I mean, the fact that you had to get incredibly creative in coming up with a way to even find them so that they could be measured indicates the distance we have to go. If you can't measure something, you can't improve it. And I appreciate you and the rest of the team taking the time to study this topic. And Karen, thank you for spending more than an hour of your time helping us understand the results and repercussions of your work. On behalf of Dr. Martha Twaddle, who had to jump off because she's on clinical today, and Amy Kelly, Janet Bull, Dana Lustbader, and Caitlin Brennan. Thank you so much for spending your time with us.
Thank you all for having me. This was great. The questions were fantastic. It's made me think of all sorts of additional things we should do with this group. So stay tuned. We'll try to have more stuff back for you eventually.
Thanks for your work, Karen.
Great job,
Thank you, Karen.
Thank you all.
We'll post the recording of this and the podcast version on the Cyft website. And there was a request for some of the other references that you made, the other algorithms that have been updated. So I'll bug you for some of those and we'll try to put that out there. And thanks again. Thanks everyone for joining, and we'll see you next time.
Great.
Thanks.
Bye, everyone.
Bye, everybody.